Welcome to today's webinar. My name is Joyce Coleman, and I'm the Executive Director of the Vasculitis Foundation. I would like to thank all of you for joining us today. A few housekeeping items before we begin. Please make sure you click on the full screen icon in the upper right-hand corner of your laptop in order to capture the optimal screen resolution for today's presentation. We ask that you please hold your questions until the end of today's presentation, at which time we will open the Q&A session, and you may submit questions directly to our presenter. Additionally, today's webinar will be recorded and will be available online. Before we begin today's presentation, I would like to issue an invitation to all of you to join us for our 2017 Vasculitis Symposium in Chicago, Illinois, June 23rd through the 25th. We hold the symposium every other year, and it consists of general sessions, breakout sessions, and time for you to meet with other patients and family members. We ask our vasculitis experts to come in and present the most current information on vasculitis, the individual forms of vasculitis, treatments, and research efforts, both recently completed research as well as ongoing research and research being conducted in the near future. We hope that you will visit our website, www.vasculitisfoundation.org, to learn more about the symposium, and we hope you will join us in Chicago in June. Now I would like to welcome Dr. Jennifer Gordon to the webinar. Dr. Gordon will talk about her experiences as a patient with Churg-Strauss syndrome, including the importance of setting priorities, tracking symptoms, and communicating with doctors. Dr. Gordon holds a PhD in pathology and is on the faculty of a medical school in the northeastern United States. She is an NIH-funded biomedical research studying 2 rare diseases. She was diagnosed with EGPA Churg-Strauss in 2014 and recently became a patient partner on the Vasculitis Patient-Powered Research Network, or VPPRN. Dr. Gordon serves on the Research, Innovation, Planning, and Experiments RIPE Working Group. I'd like to welcome Dr. Gordon to the webinar.
So I'd like to start by telling you a little bit about what's happened to me. I started out, like many of patients with vasculitis, was healthy and didn't really have many problems. I did develop asthma as an adult and was taking lots of inhalers and things like that, which didn't really seem to do too much. But in general, I was pretty healthy. Never really got sick, never took off from work, never got colds or anything like that. And then a couple of years ago, I developed a really severe case of laryngitis, and I remember exactly when that was because I was at a conference for work and I had to give a presentation and I couldn't speak at all. My voice got a little bit better, but I was having trouble teaching and giving lectures to students. So a little bit later, at the end of the spring semester, I went to a specialist for vocal cords to figure out what was going on with my voice. And he told me that I had partial paralysis of my right vocal cord, called vocal cord paresis. And it's a kind of unusual thing, and he wasn't really sure what caused it. It could have been viral, or not really sure. And during the workup, he also told me, by the way, you have chronic rhinosinusitis, which they found when they did some MRI scans. So that summer, I got vocal cord surgery to try to improve my voice, and it's a lot better, but I still have issues with it, so please bear with me if my voice starts to go out a little bit toward the end of the webinar. And then other strange thing happened. About a month or so later, I got some purpura on my lower legs, and I really wasn't quite sure what that was. So then, a month or two after that, I started to develop really bad respiratory congestion and mucus and everything in my lungs. And my asthma doctor tried a couple different courses of antibiotics with me, and nothing really seemed to work until I tried a course of prednisone. This was the first time I had taken prednisone, and I had a really very dramatic improvement very quickly. But then when the couple days of prednisone were over, all the symptoms started to build back up, and the congestion, etc. So we went through some different treatments. Nothing seemed to really be working. So I had a CT scan a few months later, and the CT scan showed that I had something called bronchiectasis, which is a form of COPD that's caused by chronic inflammation in the lungs. And I also took another course of prednisone. And this kind of gave me my first, what I call, lessons from prednisone. So the lesson I learned here was, first of all, prednisone really works, and it works really fast for me. But it also made me realize that, first of all, there was something really wrong with me, and my lungs had deteriorated quite a bit. I didn't realize how badly until I had taken the prednisone, which really cleared out all the inflammation. And now I had this diagnosis of bronchiectasis, which I had never heard of. And I really felt like I had to get to the bottom of this. So I started reading everything that I could, studying bronchiectasis and these other strange things that were happening, like the spots on my legs and the vocal cord problems. And I went to a bronchiectasis center to see a lung doctor who specialized in that area. And we started working through trying to figure out what was causing the bronchiectasis. Most of my labs were normal, and the tests were all normal, which is good. I did have some elevation in eosinophils in my blood, but it wasn't too bad. And then the congestion and everything started to come back again right on schedule. So when I was going back for a follow-up with the lung docs, now I had all the inflammation and all the congestion that I had had previously, and they retested some things and they found that my eosinophils now were really high. And that gives me my second lesson from prednisone, and that was that prednisone reduces the eosinophils, and this is in fact what you want prednisone to do, to decrease the inflammation. But at the same time, it was interfering in our ability to measure some of the things that were going wrong to try to make a diagnosis and figure out what was happening for me. So I made a decision at that point to myself that I wasn't going to take any more prednisone or any more antibiotics or anything until we could get to the bottom of what was going on. So eosinophilia is a relatively uncommon thing, and there's a pretty short list of diseases that have eosinophilia. So I really started reading everything I could about eosinophilia and the other symptoms that I was having, and I kept circling back to EGPA, or Churg-Strauss syndrome. And all the patient stories I was reading, I could see this common theme that they were really struggling sometimes to get a diagnosis, and that sometimes these delays could cause a problem. So I was very aware that if I really did have this type of disease, that I should be very aggressive in trying to get a diagnosis. Then a couple of months later, I started to develop some problems in my hands. I had tingling and numbness and pain in my arm, and I was dropping things and knocking things over, and I thought that this could be a sign of the peripheral neuropathy. And I knew that if it was peripheral neuropathy, that maybe I really did have Churg-Strauss. So I went to a neurologist who went over all the things that, like on this slide, and other details in my history, and he did an exam, and he told me, yes, I did have peripheral neuropathy, and he thought that I had Churg-Strauss. So at that point, because the peripheral neuropathy was being caused by the vasculitis, he said that rheumatology needs to take the lead on this, because we need to manage the vasculitis in order to control the peripheral neuropathy. So fortunately for me, I had one of the world experts in vasculitis right in my area, in fact in the hospital system where my other docs were at, and I was able to see him the following month, and he made a diagnosis of EGPA, or Churg-Strauss, based on all of the information. So I kind of refer to this in my own timeline as BC, before Churg-Strauss, and AD as after diagnosis. And for those of you who are keeping score with the current criteria for EGPA Churg-Strauss, I had adult onset asthma, I had a mononeuropathy and a polyneuropathy, sinus involvement, the pulmonary involvement, eosinophilia, and then later on I would have some the purpura biopsy, which would show vasculitis. So that takes me to the end of step one, which is getting the diagnosis. And I know we all have been through this. You get to that point and you think, wow, this was the hard part, right? But maybe not. So we know that the goal is to get to remission, and the way to get there is through treatment. So I just want to mention a couple things I think that are important about what we're talking about when we talk about remission, because there's so many different potential definitions. At its most basic, it means no activity of the disease. This means that the vasculitis would be silent and that there's no inflammation that's causing any damage. And you can think about this in a number of ways. This could be drug-free. You're not on any medication at all and the disease is in remission. You might be on a very low level of prednisone, and some of the doctors might call this remission. Or you could be using one or more drugs to try to keep your immune system in check in a form of what we would call pharmacological remission. But at its core, the goal here is no disease activity. So what exactly is the disease activity? So vasculitis is an autoimmune disorder. And normal people, when they get an infection, they say, you know, I'm fighting a cold. That's a good thing. Their immune system is doing its job. But for those of us with an autoimmune disorder, what's happening is our immune system is overactive and is attacking itself. And that is the disease activity. If we look at this on a cellular level, I think this cartoon is a good illustration. You have your immune cells, and for some reason, they're looking at other cells in your body, and they see an enemy or an intruder, and they're attacking them by mistake. In the case of vasculitis, this would be your immune cells attacking your blood vessels or the vasculature. So how do we control the inflammation? How do we control the disease activity? That's the step two, the treatment. So in terms of setting the goals and the priorities, in some ways the big ones are pretty simple. The goal is remission, which means no disease activity. But it's not quite so simple as that. We need to make sure that we are minimizing the damage caused from the vasculitis, and at the same time, since the treatment itself can be toxic, we need to balance that with minimizing the damage that can happen from the treatment itself. So my initial treatment plan was to use prednisone, high-dose corticosteroids, followed by a steroid-sparing agent like azathioprine or methotrexate. And then the idea would be to be able to slowly taper the corticosteroids and rely on the steroid-sparing agent in order to control the inflammation. So each of these drugs has a particular role to play in controlling the disease activity. So I think it's really important to make sure that the patient knows exactly what is the treatment goal and the treatment plan. And we don't usually talk about these things directly when you're in the office with your doctor. But it's important also to understand what is the role of each of these drugs, because they have a different role to play, and how is each of these drugs going to help us to reach that goal. And then also to think about how the goal is going to be measured. Is that blood tests or imaging or some other form? And this may not be a value in a particular blood test or a number of milligrams of prednisone, but more of a clinical goal in terms of disease activity and how the patient is feeling. So I started my treatment in October of 2014 at 60 mg of prednisone. We tried azathioprine, but that didn't go so well, so we switched over to methotrexate, and I started with injections. And during my first taper, I had my first flare. So when I got below 20 mg of prednisone, I developed purpura and peripheral neuropathy. And at that point, my rheumatologist offered me the opportunity to participate in my first clinical trial. And this was using mepolizumab for the treatment of EGPA. This is a randomized placebo-controlled double-blind study, so that meant that I wouldn't know if I was getting the drug or the control, and neither would my doctor know which one I was getting. So I file this in the category of things they don't tell you. And for me, it seemed like trying to get the treatment right might be taking a while. So in my first year and a half of treatment, I was on prednisone between 20 and 50 mg for the whole time. And I went through 5 tapers and 5 flares every time I got below 20 mg of prednisone. I did 1 clinical trial, which after the first 3 months during the taper, I had a flare, and my doctor thought I should come out of the trial because it looked like the treatment wasn't working for me. I took methotrexate for most of that time, and we also did 2 courses of rituximab. So when I was getting ready for the webinar, I put together a little graph of my clinical course for the last 2.5 years, and I thought that this really illustrates all the things that I have been going through pretty well. So in red is a graph of the prednisone dose, and you can see the taper and then the increase and the taper, etc. And the different flares are marked up at the top. And then in addition to the prednisone, I added on the other drugs that I tried. So I had methotrexate during my first taper and flare, and then I did the clinical trial for mepolizumab, not knowing whether I was getting the drug or the placebo. Had another flare. At that point, we added rituximab. I had a couple more cycles of flares. We added another course of rituximab, went back on the methotrexate, and then I continued to have flares, and these were mostly peripheral neuropathy and purpura. So we decided to try IVIG. Some vasculitis patients may be taking IVIG to help them if they're immunosuppressed in preventing infections. In my case, we were using IVIG to try to block the peripheral neuropathy. So the immunoglobulins are used in order to prevent my immune cells from attacking the blood vessels supplying my nerves. So I started to get monthly treatments with the IVIG, and this really seemed to help, and I was able to start to taper for the first time below 20 mg of prednisone. And then I had another flare after I got down to 10 mg. And this wasn't the peripheral neuropathy. This time it was respiratory and sinus. So I started taking mepolizumab. This was an open label study, so I knew I was getting the drug. And we added in another course of rituximab. And gradually my symptoms subsided from my nasal, sinus, and my lungs. And I've been able to maintain 10 mg of prednisone for the last 6 months. So this has been a huge accomplishment. I'm now on 10 mg of prednisone. We just earlier this month decided to discontinue my methotrexate injections. I had had a flare almost every time I was on methotrexate, so it didn't really seem to be doing much to help me. And these drugs can be toxic, so we thought it would be best to not expose me to more toxicity without any benefit. I'm getting the mepolizumab monthly. I've had 3 courses of rituximab so far, and I'm getting monthly IVIG for now to help control the peripheral neuropathy. So at this point, we're going to try to keep going, and it's one day at a time. So based on my history, I guess I would file this in the things they don't tell you. I'm probably going to have more flares. So I need to be vigilant. I need to be looking out for those symptoms, and I need to be tracking how I'm doing over time. So I want to say also what my other labs and things showed during this time, because I think that's important. So this is me, but this is not my doctor. I mentioned that I had eosinophilia early on in part of the diagnosis, and this was really high. But on the prednisone, the eosinophilia is well controlled. So this is really not a marker we can use to look for disease activity. I'm also ANCA negative, so we can't follow ANCA, even though there's not much evidence that there's a direct correlation between disease activity and ANCA. And also my SED rate and my CRP are all normal as well. So we didn't really have any markers to follow. So how do we follow my symptoms? This was by measuring the actual clinical signs. So what I've shown here in gray are the scoring for my symptoms using something called the BVAS score, and I'll talk a little bit more about that in a few minutes. And you can see that when I had all the clinical symptoms, this directly correlates with the low doses of the prednisone. So I would have a flare on the low prednisone, and then when the prednisone is high, my disease activity is very low. And here's that respiratory flare that I mentioned, that we were able to keep the prednisone level low while we treated with some of the other drugs to control those symptoms. So what are we really measuring when we're looking at disease activity? So we all know you can use a pain scale, and this might be really great for the kind of acute abdominal pain when you go to the emergency room, but it doesn't really help us in managing a complex disease like vasculitis, which is chronic. You can use an activity tolerance scale that I put down here underneath, which sort of gives you an idea of how well you're able to function, but this is not really specific either. And one of the challenges here is we have to tease out what the effects are from the drugs versus the effects of the disease. And I usually like to think of this as the who's driving the bus. So if vasculitis is driving the bus, this is disease activity, and we need to treat this. But if the drugs like prednisone are driving the bus, this is not disease activity. These are side effects from the medication, and we need to be able to figure out the difference between them. For most of the time during my treatment, unfortunately, I have not been able to drive the bus. I've been in the back seat. So when we look at this chart and we try to figure out how to score the symptoms, which are going to be the good days and which are the bad days? Well, as I'm sure most of you can sympathize with who have taken lots of prednisone, it's really hard to have good days when you're on 50 mg of prednisone. And of course, it's really hard to have good days when you're having flares of disease activity. So exactly where in here am I going to find the good days? Lately, down at the 10 mg of prednisone, it's been a lot easier to manage, and I'm really happy with that for now. So one of the things that's helpful to do is to break out some of the symptoms that might be more easy to measure. When we talk about lung problems, for example, there are many ways you can measure lung function and shortness of breath and activity that might be easier to measure than some other things like headaches and some of the joint pain. Purpura, for example, you can actually see on your legs, so that can be a good sign. But some of these can be really tricky to measure. And it's also difficult to know if they're coming from the vasculitis, or they're coming from the medication, or in the case of something like headaches, it's not even really clear which part of the disease spectrum is causing this. So this is the BVAS that I mentioned, and this is something that the vasculitis clinicians use to score the disease activity. And it's pretty in-depth. But I'd suggest that you take a look at it. I find it really useful. If you Google BVAS score, or you can go to this link here for an online calculator, it basically breaks down all the different symptoms that the vasculitis doctors feel are part of the disease spectrum by organ. So for example, if you have lung issues, it will break down the different types of symptoms that could be related to the vasculitis. And I use this to review just to see if there might be something that I overlooked about myself that might be one of these categories that I wasn't thinking about. And you can Google these terms if you don't know what they mean, learn about them, read about them. And I like to look at it from time to time. Another way that you can score disease activity is by looking at quality of life measurements. And this is a fairly typical score for that, where it's really talking about how well you're able to function and do your what they call activities of daily living. And you can Google quality of life score to find examples. These are really helpful, I think, for talking about like how you're doing over time. But they're not really used for setting a treatment goal, which is very specific to the organ and the disease itself. So why is this so important? This is a really critical slide. The goal here is to try to figure out what the difference is between new or worse disease activity, new symptoms or worsening symptoms directly caused by the vasculitis. because this is something that the clinician needs to treat, versus something that might be persistent disease activity. Sometimes you may have disease activity that's around for a while or takes some time to resolve, and you don't want to overtreat because the medication can cause problems. We also need to be able to figure out what might be permanent damage or prior damage from the vasculitis, from previous flares or something like that, because treating prior damage is probably not going to be able to improve damage that might not be changing or may not improve. And that's just going to add more medication and can cause more issues. And then, of course, we have to figure out what are all the other things. If you're having problems with your lungs, is that caused by the vasculitis, or is it caused by an infection? Because you don't want to treat it as if it's vasculitis if you should be treating an infection. So how does this work in reality? Well, I think about this with my own peripheral neuropathy. We can use that as an example. So I know I'm having new or worse disease activity when certain things happen that start getting worse. Like my big toes start to go numb. They feel like they're being strangled. I get lots of pain on the soles of my feet, so I have to put flip-flops on because I can't walk around in hardwood floors at night. And those are kind of my signals that, oh, something's getting worse. Now, once I start treatment, because I'm in a flare when I start to have these problems, it can take a couple of months for some of the pain to go away. So I might be walking around in the flip-flops for a while, but that doesn't mean that it's new or getting worse. This can be persistent pain and persistent disease activity because it takes a while for the blood vessels to repair and for the nerves to repair. I also know that I have some permanent damage. I have some spots in my heels that I don't have any feeling in anymore, and it's been a couple of years, so I don't expect that that's going to come back. But it often takes a while for the new and worsening disease and the persistent disease to come back to that baseline. And I also know there are other causes that can lead to these symptoms. Like when I go on the airplane at altitude, I have a lot of pain in my feet and my hands. When I'm on high prednisone and I have a lot of swelling in my legs, this can also cause problems, and in the summer heat and humidity. So we wouldn't want to treat these as being active vasculitis. So there's also the issue that sometimes the medications that you're on can cause the very side effects that you might be trying to deal with in the first place. So how do we navigate all this? Well, this is really a teamwork effort, and this is my treatment team. My clinicians, my rheumatologist is the head coach, and then I like to think about the other specialists as the special teams, and then me. So we've got this team together, but it's really me. I'm the one that's in the game, and I'm the one taking the hits. So it's really critical to have an experienced team. And if your team is not experienced, then I suggest that you try to find clinicians that really understand the disease. You can find some great resources for that through the Vasculitis Foundation website. So what is my job as part of this team? Well, first of all, I have to be committed to the treatment goal and plan. I need to know them. I need to understand them. If I'm not committed to them and I'm not sure about what they are, then we need to go back to the drawing board, and I need to meet with my team so that we're all on the same page. Because if I'm not committed and I don't know which way we're going, then I can't get in there and do my job, which is to execute the plan. So I'm the one there every day. I have to make the observations and take notes. So the next time I'm meeting with the team, I can give them feedback. I can tell them what worked, any deviations from the plan, what are the signs and the symptoms, did I have anything get worse, do I have anything that it might be a side effect, is this working for me, and what kind of suggestions can I make, something that might make an improvement. So when we put this all together and I looked at this slide, I thought to myself, this chart really represents teamwork to me. And this is an effort primarily between me and my rheumatologist. And I think that this graph really speaks to what you can do with an experienced clinician and engaged patient, where we have a shared goal and we are extremely focused on that goal, which is minimal to no disease activity. And we walk through and we make adjustments to the plan together. We change one thing at a time, and then we reevaluate and we see what's working. And this is really based on communication between me and my clinician and the rest of the team. And this is the clinician listening to the patient and the patient listening to the clinician. And this is built on trust. So I want to say a few things about how to approach doctor visits, and there are lots of good resources to read about these things. So I just want to highlight a couple of my own favorites. First of all, the clock is ticking. We all know this. When the clinicians come in, they've got a long list of people to see and a short time to do it. So you need to be organized and you need to be ready to go. And this is really sometimes overwhelming if you're not feeling well or you're not really sure what's going on. And then, as I said, this is me, but this is not my doctor. If this is your doctor, if you don't feel like your doctor is listening to you, then I really suggest that you try to find another doctor. So I'm not going to go through the basics very much. You can read these on the list just to make sure that you're prepared to give a summary. So when your doctor says, "How are you doing?" you have an answer. You have a 2 to 3 minute answer that's going to give a complete summary of what you think is new, worse, better, the same, how things are going. And try to limit yourself to like what your one big question is. You know, what is your one major goal or accomplishment for that appointment? And get it out there early. And ask questions, because the doctors will only answer the questions that you ask them. Under the basics too, there's some great suggestions that many people have given. I'm sure many of you know. Bring along someone who can help you repeat back instructions. I'd like to focus on this one. It's really hard to multitask. Everybody thinks they can multitask, but they really can't. So when your doctor's typing and looking in your chart and nodding their head, you don't really know how much they're able to absorb of what you're saying. So I suggest that you don't talk while they're typing and looking in your chart. Just wait. Wait a few seconds. Try to be patient. I know it's hard because you've been preparing for this and it's a very important visit. But just wait until they're looking at you and you have their full attention, because you really don't want them to miss what you're saying. And then when you leave, you need to know what's your homework, and you need to make sure you've got your next appointment, referrals, and stuff. So then I get to the advanced slide. So what I like to do before I meet with my doctor the day before is I sit down and I give some thought to what I'm going to say, how I'm doing, and the symptoms that I have. Can I break these out into what I think is new disease activity, or persistent activity, or prior damage, or the other category, and really think about it. I also like to think, what is going to be the treatment decision? What is my rheumatologist going to recommend we do? What do I think we should do? And why? So I can kind of compare what he thought and what I thought and what we decided on in the end. And you may think that you're not sure about these things, but I guarantee most of us know when we're walking into our rheumatologist's office when they're going to tell us we have to increase the prednisone. And most of us know when we're doing well and hoping that they're going to let us decrease the prednisone. So if you take this a step further and start to think, why do you know this? What are the things that make you think this? What about the other medications that you're on? What kind of lab tests can be used to help you measure which direction you're going in? And then another thing that's really important is to do this from time to time for yourself, is to check in and see how you're doing. What areas are you doing really well, and what areas can you improve? And if you Google taxonomy of burden, it will take you to this chart on ePatient Dave's website. And I think this is a really fantastic chart. It breaks down into so many different areas that your whole life is impacted in managing chronic disease like vasculitis. It's really a part-time or even a full-time job for many of us. And I like to walk through every few months exactly all these areas and just kind of give myself a few minutes to think, how am I doing with these things? Which of these things can I make improvements on? Which of these things do I have down? And this can also be helpful for caregivers and family members to understand the scope of all the things that you have to manage, and also to open up some discussion about some of these things, to talk about how you're doing as a team, how you're doing as a family with some of these issues. So next I want to say a few things about more general planning. And I think that this is really critical to make plans. And the reason for this is, like Eisenhower said, it's not really the plan. The plan kind of goes out the window as soon as the battle starts, for example, but it's the planning. It's the thinking through of all the what ifs and all this, plan Bs and plan Cs and how you're actually going to get things done. So I like to start with the essentials. These are the non-negotiables for me. I need to make sure that I'm on target with my diet, my hydration, my sleep schedule, my medications and supplements that I'm taking. And I get up in the morning at the same time, I take a shower, I build in exercise, etc. And then you can add one or two more things to this list, but this is my essentials for every day. As long as I get through these things, it doesn't really matter what else I do. And in fact, I can get through most of these maybe by 11 a.m. So if I need to take a nap after that, I'm still good for the day. I'll just add in terms of diet and the things they don't tell you, potatoes are a great source of potassium, especially the skin, but don't expect your doctor to recommend that you eat French fries. But I'm just saying. Also, in some ways, vasculitis has really simplified things for me. Before Churg-Strauss, emergency plan, you're thinking about bottled water and flashlights and all kinds of stuff. But now I have a new, more simple plan. I can handle almost any crisis as long as I have a big bottle of prednisone. As long as I have my meds and those other critical supplies that I need for myself, I can figure out all these other things. Family members can work on these for me, and I can focus on the things that I really need for me. Fortunately for me, I've been able to continue working full-time throughout my treatment. And I've sort of taken that whole concept that, we all know vasculitis is really an invisible illness for many of us. And I've sort of flipped it around. And I've been actually quite amazed that only the really close colleagues of mine know when I'm not feeling well, and everybody else really doesn't seem to notice. So I kind of think of this as I have an invisibility cloak at work, and nobody knows that I'm sick. I can go to meetings, I can go to give lectures, etc., and nobody really knows what's going on, so I'm able to continue doing what I need to do. I rely on my essentials to keep me going. That I've got my sleep and eating and all that stuff planned ahead. And I've really used my disease and my treatment time to give me a chance to reset my priorities and goals and focus on what are the major things that I want to get done at work. What are the things that only I can do? What are the things that are really important? Not the things that are urgent coming at me in my inbox. And really being ruthless in eliminating things that are not focusing me on my main goal and that are distracting me. Travel is a big one that can be hard to manage, especially because you're going to have additional physical and mental stress, and your essentials become even more important. And I do travel every now and then for work. I try not to travel too much, but I plan ahead with extra supplies of medications. And I also scope out when I'm looking at the hotel, whether it has a refrigerator, how am I going to eat, what am I going to do. I look and see where are the nearest emergency departments. And in particular, I like to look and see where are the academic medical centers in the city that I'm traveling to. Are there any local vasculitis specialists? I go to the Vasculitis Foundation website and see. Because if I have a choice, if something does happen to me when I'm out of town, and I can go where I know there's a vasculitis center, then I know there are going to be clinicians there that are going to be able to treat me the best, and contact my own clinician if needed. And you can also ask your doctor if you're going to be away for a while to recommend a local physician. It's a pretty tight network, and they may have some colleagues in the area for you. So I just want to say a few things about mindset. Mindset is absolutely critical, but there are many great resources you can use to approach your mindset. I just want to say that you really need to be good to yourself. And if you are engaging in self-sabotage or negative self-talk or blaming or making excuses and things like that, that you're not getting the things done that you need to, then you may have issues that you need to address with your mindset. And you probably had these before you got vasculitis, because you're still the same person you were before you got vasculitis. But now sometimes vasculitis puts a magnifying glass on these things. And that actually can be an opportunity for you to try to address some long-standing issues, get a fresh start and a fresh look on it, because you will be your biggest enemy, and you will have a very difficult time succeeding if you are fighting with yourself. So I encourage you to think about your mindset and what you can do to change that and improve it. So a couple of the lessons that I would summarize that I have learned so far from vasculitis. Resilience and persistence. It's really amazing what your body is capable of going through, especially if you are focused and you are taking care of yourself along the way. I am the expert of me, and you are the expert of you. And through this process, I have learned even more to trust myself and to listen to my body. I know when I'm not feeling well. I know when I'm having symptoms, and I need to make sure that my treatment team is listening to me, and I'm listening to myself, and we're taking care of these issues. Vasculitis has also given me a lot of clarity in terms of setting goals, and my making of decisions is very, very simple now. I have one goal, and that is this good for my health? And if I make a choice to do something, how is it going to impact my health? And that's my number one goal. Also, I think it's important to keep in mind, as Master Yoda says, your priorities are what you do and not what you say they are. Not what you say you're going to try, but what you're actually doing. And then, of course, some days are just going to suck. And that's okay, because this is a marathon, not a sprint. And we need to make these kind of incremental and small improvements over time, because that's how you win the race. So I file this in the things they should tell you, but usually don't. There are always more treatment options. There are always more second opinions. There are always more things to try or new approaches. So if you feel like you're not moving forward, or that you could be doing more, or you're struggling with something, you need to find ways to get more opinions, more advice, and more ideas. There's always something else to try. And then finally, I would just add, forget about making big goals and long to-do lists and all kinds of plans, and try instead building tiny habits. This works really well if you're struggling with flares, or you're on lots of meds that are giving you side effects, because sometimes we just don't have the energy or the capability for the big goals and the long to-do lists and checking things off. But if you can spend a little time optimizing the essentials, tweaking your diet, making little adjustments and things to your sleep or your exercise or your mobility, these can really go a long way over time in helping you build your resilience and helping you to maintain your health. So I would suggest that you ask yourself, what is one tiny thing you could do right away? One tiny little change, like drink more water, or take a walk after you have a meal, or set an alarm on your cell phone so you don't forget to take an afternoon med. And then look at the taxonomy of burden. Sit down and ask yourself, what is the one thing that would make the biggest impact for you? And many of us probably know a couple things off the top of our head that we know we should be doing. So why aren't you doing that? Why are you not making progress? What's holding you back? If you can find one big thing that could make a huge impact, maybe that would be worth trying. And then again, just to focus that it's about making those small adjustments. So the last thing I would say is, I think it's really essential to educate yourself. Learn everything you can, talk to patients, talk to clinicians, get online, go to conferences, because I think knowledge is survival. So thank you for attention. I'll stop there and turn it back over to Joyce.
Great. Dr. Gordon, thank you so much for your assistance. I mean, what a great, great presentation. We were going to do a poll, but we're going to skip that and just move directly to the questions and answers. So if anyone in the audience has a question that they'd like for Dr. Gordon, Jennifer to answer, you can submit it through the question window or through the chat window. And then I'd also like to bring Ed Becker, our Director of Marketing, into the conversation. Ed, I know you've been monitoring social media. Do you have any questions from there?
Yeah, actually, we've got a number of questions that have come in. The first one is, how is your experience in your education and your career and what you do? How has that helped you to be a better patient? Has it given you more confidence and greater understanding of the disease? And the second part of that was, how can I get that and become more educated?
Yeah, that's a great question. So, I never heard of EGPA Churg-Strauss before I got sick and diagnosed, and I never heard of bronchiectasis or many of these other things. I had a big advantage being able to read publications and things and kind of speak some more of the language with clinicians. But I think it's really about knowing yourself. When we know when we're not doing well, we know when we're sick, and it's a matter of being able to assert yourself, which is really a challenge when you're sick. So I think that we all have that knowledge within us. It might not be the level of technical knowledge. The technical knowledge we can learn. The self-confidence and the wherewithal to know when something's not right with you, I think that's something that we know a lot more than we think we do, and you need to dig deep within that. And don't be afraid about the amount of information that you need to learn. Just take it in small bits.
Thank you. Another one is, what role has alternative, or I guess complementary therapy, alternative therapy played in your own treatment and recovery?
Well, as most of us with vasculitis know, we're on a lot of very aggressive treatments sometimes to try to control the disease. And there's often not a lot of evidence behind some of the treatments that we have, but there's a strong scientific or medical rationale that is guiding our treatment. So in any type of complementary medicine needs to be an add-on to that, in my opinion, for myself. I've used supplements and things from time to time to try to help with different symptoms, but I'm always trying to keep in mind that I need to make sure I'm telling my clinicians about anything that I'm taking, and that we're always on the lookout to see if these are going to have any impact on the main drugs that I'm relying on, my prescription medication, because I wouldn't want to have those supplements impact their effectiveness. So it's really important to talk to your doctors about that. And I think most doctors are pretty open about trying alternatives and complementary approaches.
Thank you. Another question here. As a researcher, where do you think the focus should be? Should it be on focusing and developing better diagnostics so vasculitis is diagnosed earlier, or should a focus be more on the treatment and developing less invasive treatments, or is it something both of those are equally important?
Yeah, that's a great question. So as a basic scientist, I'm always looking at mechanism. What is the actual mechanism? What cell is talking to what cell, or what part of a cell is damaging what cell? And in the process of figuring out what those mechanisms are, this is what often leads to a new biomarker or a new potential treatment, because when we understand what's happening on a cellular or a protein level, then we can understand what would be a good rationale for another treatment. So I think that the research should be focused on understanding mechanism with a goal toward translating those into treatments and into different types of diagnostics. So I think they can all work together. And when you have a community that is working together with patient biobanks and things like that, like's happening through the VCRC and the Vasculitis Foundation and the VPPRN, that is an opportunity to capitalize on all of those things together. because they're really, the goal is the same, which is improving the patient outcome.
Thank you. Okay, 2 more questions here. This person writes, I'm currently in remission, but I'm terrified of having a relapse and having it flare. What should I be looking for, and how can the person says, how can I keep myself from going crazy worrying about a flare?
Yeah, well, that's a mindset question first, in that there are some things you can control and some things you can't control. And what's the definition of a relapse, and how are you going to approach your everyday life? I'm pretty sure I'm going to have more relapses, and I'm okay with that. I just need to recognize them early and do what I can, and I need to be assured that I'm doing everything that I can to work with my doctors and see what's going on as soon as possible, so that I can go back on treatment if needed to control the relapse. So I understand that it can be really scary, but I like to focus instead on the things that I can control. Like I said, I like to look at the information the clinicians are using to score disease and look at different organs, and that helps me be on the lookout for things I might not be thinking about could be vasculitis. And knowing myself and being able to compare, how am I doing now versus a few months ago? Because if you can catch these things early, then it's going to be much easier to try to control the disease.
Thank you. Last question. Where do you think we need to put the focus to educate the medical community? Is this something that we should be, as a community, reaching into the medical schools to introduce them and make them aware of vasculitis?
Well, I think that when we look at training of residents and fellows, and the funding that the Vasculitis Foundation has been given to the fellows for training, that's one great way. And running some of these continuing medical education seminars and symposia is another one. I think there are some other opportunities that I know that some of the clinicians associated with the Vasculitis Foundation are working on, to try to train clinicians in recognizing how to diagnose the vasculitis, because that's really the first step. I think many clinicians out there who are not really well versed may miss some of these signs and not be sure. And if you can't get the patient identified as potentially having vasculitis, then you can't really make any progress. So that's probably one of the first steps. And then, of course, once the clinicians are engaged with vasculitis, then they'll know where to go to network about treatment. I think we should use web-based tools and some other methods to try to get this information out there, especially to the junior rheumatologists and the residents. And I think the Vasculitis Foundation can help with that.
Okay, thank you. Actually, one comment came in. I think you'll like to hear. Someone said that this has been a fantastic webinar and they thank you. And so with that, I'll turn it back over to Joyce.
Okay, great. Ed, thank you so much. I have a couple questions that have also been submitted, Jennifer. One of them was, how do you have any suggestions for how do you deal with doctors who work independently from other doctors on your team? This patient lives in a small city and none of her doctors have experience with the CS. I think she meant CSS, and she went to Cleveland Clinic to get diagnosed, and she's the central point to all of these doctors. She finds it very frustrating. Do you have any suggestions for her?
Yeah, it can be a tremendous source of frustration. I have had a couple of clinicians where I felt like I was going in and basically summarizing what my rheumatologist said to them, and not really sure how much value I was getting out of some of the specialists. I think it's really about setting the goals. So how are you setting your goal, and how is each clinician on your team helping you reach that goal? And if they're not, then maybe you need to try to find another one, or you need to talk to your head coach and be honest with them and say what might not be working, or which specialists you're having difficulty or struggle with, and ask them to work with you to try to find out what you might do to fix things. But step one is acknowledging where the issues may be. You know, some clinicians might just not communicate very well with another one, or you might not get along with one person. Sometimes that happens, and that's okay. But you need to recognize the problem and then ask for help and how to address it, because there's always something else you can try. And be patient. Not just a patient, but be patient too.
Be patient. Thank you. Another question that came in, Josh asked, is there a research site that you trust the most? And I'm not sure if he's talking about where you find your medical information, or one of the, if you have any ideas.
Well, I can tell you what, when I teach medical students and graduate students, when we talk about this is a big topic, not just for patients, but for clinicians too. You know, I do have some resources through my university, so I can see some of the things that clinicians have access to, and I can access all the research papers and clinical papers, and I can read them. But you know, you need to use your critical thinking, because you need to look at who's funding the study and who might have an opinion or an agenda. So it's not such a simple answer, unfortunately. And I think that's an area that I would like to see the Vasculitis Foundation be able to help patients and possibly even clinicians with more, because I think the resources at the Vasculitis Foundation, through the clinicians that are involved, can help to direct us to some reliable sources of information.
Right. He sent an additional comment. Yes, the internet is bad in general. So, yes, as you said, identifying, the resources that are viable, that are, who are up to date, etc. And the VF can we absolutely should be bumping up our work in those areas. Another question that came in, you had mentioned that you were on a couple clinical trials. How did you find out about those? Is that something your doctor suggested, or is that you researched and then asked to join?
Both, actually. So I'm signed up at clinicaltrials.gov. Every time there's an alert about any ANCA-associated vasculitis study or an update, I get an RSS feed on that. So I usually know about it as soon as it's in the database. But my clinician, my rheumatologist, who's an expert in vasculitis and works with the Vasculitis Foundation and the VCRC, he's involved in many clinical trials, because these are usually multi-site trials since they're rare diseases. So he's one of the participating centers, and I can have access that way. But I also do my own homework to see what's going on out there.
Great, thank you. And that was clinicaltrials.gov, which
Yep.
lists all of the trials that are going on, both in the U.S. and internationally. You can see trials that are recruiting, that are getting ready to recruit, or which have finished. It's a great resource. You just you go out, and in the search box you can put in vasculitis, or you can put in EGPA, or whichever form of vasculitis you have, and it's a great resource for seeing the potential trials that are going on. So I highly recommend that one also. Another question that I wanted to, one person just wanted to echo, thank you so much for this information. How can we get a copy of the presentation? And we are recording the webinar, and it will be available once it gets edited, and we'll be placing it back out on the website. And the PowerPoint presentation, hopefully we'll make that available also. One other thing I wanted to mention is that Dr. Gordon recently joined our Vasculitis Patient Powered Research Network, our VPPRN. She is one of our new patient partners, and she's going to work on our research, innovation planning, and experiments working group. We call it our RIPE group, R-I-P-E. And Jennifer, I wondered if you would talk just a little bit about what you hope to accomplish while serving on the RIPE, what the working group is working on.
Yeah, I'm really excited. I'm really excited to be working on that group. I'm hoping that some of my knowledge about research is going to be useful to the committee, because the committee, pardon me, the committee is going to be looking to see what sort of trials, what sort of research studies could be done through the VPPRN. And there are many groups working with other PCORI units that have been making great progress in this area. And the goal is to try to look at, from the patient's perspective, what are the most important things to us, and how can we help to move research and clinical treatment further in these specific areas. So I'm really excited about that.
Great. And, I just want to thank you on behalf of all of our patients and family members and everybody on the VF. We just appreciate you sharing your knowledge and serving on the RIPE. And for those of you who may not be a member of the VPPRN, that is our network registry, and you can learn more about it by going to vpprn.org. Kaylin Young usually joins us on these webinars. She's our network manager for the network. And so if you have any questions, feel free to email the VF office, and we're always happy to put you in touch with Kaylin. At this point, I think we're running just a little bit over time. Again, I want to thank Dr. Gordon for joining us today and sharing her knowledge and expertise and everything. I also want to thank everyone for attending today, being such a great audience and the great questions. If you have any follow-up questions, please send them to the VF office and we'll forward them to Dr. Gordon. Again, just thank you everyone for your attendance and your participation. I hope you'll consider attending the symposium or signing up for the VF newsletter or one of our other services. We're working on April's webinar, and we'll be sending that information out also. So I hope everyone has a great day. Thank you.